Hello and welcome to the PEDro World-Wide Journal Club. Today we'll be discussing a systematic review on exercise and preventing falls in community-dwelling individuals. I think we'll go around now and briefly introduce ourselves before we get started. Let's start off with one of the authors of the paper, Kathy Sherrington.
Hello everyone, I'm Kathy Sherrington. I'm a research professor at the University of Sydney at the School of Public Health and the Institute for Musculoskeletal Health, and I have a clinical background as a physiotherapist.
I'm Jamie Hallen. I'm also a physiotherapist. I currently do some clinical work at Prince of Wales Hospital in Randwick, and I'm the Falls Prevention Coordinator for South Eastern Sydney Local Health District.
Hi, I'm Nadeem Mossad. I am a physiotherapist working with neurological and geriatric populations, and I work clinically in an aged care facility.
Hi, my name is Emre Ilhan. I'm a physiotherapist by training, and I'm a PhD candidate at Macquarie University. This is basically directed to everyone on the panel. The review highlights the importance of ongoing exercise in preventing falls in this population that the review looked at. Is it reasonable and feasible to suggest that all community-dwelling individuals 60 years of age and older participate in falls prevention as part of their everyday routine?
I can go first in terms of the evidence. It's essential really in terms of the evidence and in terms of what we know, that the effects of exercise go away when we stop exercising. So, really we do need to get this ongoing behaviour change. But it's a real challenge in terms of how we provide that. I mean, we can't, even in a rich country like Australia, we can't really imagine public hospital physiotherapy services actually providing exercise for every person aged over 60. So I think we do need to think laterally about how we can actually deliver that. And so things like community exercise. I think we also need to look at different ways of funding these non-pharmacological interventions. So our system are very good at funding pharmacological interventions, even when they have effect sizes kind of comparable or less than the effects of exercise on falls, but our systems aren't usually that good at actually providing reimbursement for people for ongoing exercise.
I think adding on to that as well, something that I've come to notice is the stigma behind falls in general, something that we need to look towards. And it might be due to maybe trying to save face, not wanting to admit to falls. And a lot of people, a lot of patients that I've come to treat typically downplay a lot of their incidences because they feel that they don't want to admit to falls because that might make them appear less independent or less mobile than what they're used to admitting to. So I think tackling that issue as well and finding ways to have a healthy conversation with those individuals is probably something to look at as well.
I think that. No, you go, Jamie.
Oh no, I was just going to say one of the things we're probably not as good at yet is building in balance exercises from a younger or middle age part of life. So often as physiotherapists or in my clinical work, we see people once they're already quite high risk, and it's really encouraging that this paper showed that they can still benefit. But I think we have a lot of work to do in terms of how we engage that younger group of people, hopefully before they're high risk in these types of exercises, that they hopefully will then continue doing across the rest of their life course.
I think that's a really good point. And a key thing about our paper is we did the subgroup analysis that looked at how people were recruited. And as Jamie said, in the people who were at some increased risk, the interventions were effective, but they were also effective in the general population. And in fact, that was half the studies. And that's something that often does get neglected, which ties in with what you're saying about the stigma. So, if we can use that evidence to promote the idea that actually falls prevention exercise is for the whole community, not just at high risk people. the other thing from a marketing point of view, I guess, as well, is that in a number of studies, it's been found that people don't necessarily want to hear about falls, and that's not necessarily a reason that people would sign up to exercise, but other words such as promoting independence and sort of maintaining physical function and maintaining the ability to live at home do tend to be a bit more attractive. Terry Haynes in Melbourne had a really interesting finding that a lot of older people felt that other people are at risk of falls, and like other older people ought to be doing exercises to prevent falls, but not themselves. And that ties in, you know, with what you were saying, Nadine.
And people possibly don't always realise that there's something they can do about it. That people often assume that these things happen, they're just accidents, they're a normal part of life, there's nothing necessarily specific to be done about it. So I think that's another challenge that we have, is how we frame that conversation around, well, actually there is a lot we can do to stop this happening. We don't have to accept it as a normal part of getting older.
Exactly. And we need to be promoting those ideas amongst, you know, other professions. We really need all GPs to kind of think that and to be saying that to their patients.
I think as well, just adding on to that, a big part of falls prevention as well is educating people on what a fall is and what constitutes a fall, because people will often just think that if they've had a minor trip, it doesn't really constitute as a fall. Unless they've kind of fractured something or it's something major, and then after they're like, oh yeah, maybe I have had a fall. So those smaller incidences as well do count, depending on the definition, which I found in lots of other literature as well, that there was, I think now there is a consensus on the definition of a fall, whereas that probably still hasn't been taken on board by the vast majority of society. So educating them on what a fall constitutes and what that might mean for them as well going forward from those events might help to bridge that gap as well.
So Kathy, going from that, or leaping from that comment, did you find that the use of different definitions in the trials that you included in the systematic review could have accounted for differences in the findings?
No, most studies do actually use a similar definition. So it's basically unintentionally ending up on the ground or other lower surface. But Nadine's right, the general population doesn't necessarily understand that, but yeah, most of the studies have used that definition.
So another question that I guess is very relevant to today's climate is the use of telehealth for physiotherapy interventions. So in the systematic review that you and your colleagues did they include any studies that actually use telehealth as part of the delivery of the interventions?
Yeah, that's a really good question. And off the top of my head, I'm going to say no, but there actually may have been a couple of smaller studies. But yeah, the bulk of the studies certainly have not used telehealth. So the bulk of the studies are about people with an instructor, you know, in a room together, or else having had one-on-one instruction, usually from a health professional, to sort of carry that on at home. But yeah, so that certainly is something we need to know more about.
It'll certainly make it more challenging when we know how hard uptake and adherence is, even when we can deliver group-based exercise and face-to-face interventions. So it will add an even greater challenge, I think, in the current climate, especially targeting older people and having to more widely leverage the use of technology. Safety is always an issue with falls prevention and challenging people's balance, but even more so when you're potentially engaging with them remotely. So
definitely.
Yeah.
But I think we can also look at advances, I guess, in kind of video-based technology, because you know, certainly clinically, and I'm sure others would agree, it's way easier to set up a home exercise program if you've actually visited someone's home. So in terms of being able to set something up that's safe but you know, still challenging. So you know, everyone I think sure can relate to the idea of saying, well, no, let's do that exercise here. You know, here's the corner of the room, here's the nice sturdy table or the nice sturdy kitchen bench, and you know, hopefully we can get good at doing those types of things remotely as well. And so, you know, which has the potential to kind of save resources and to, you know, offer these interventions to greater numbers of people down the track.
Yeah, that's absolutely one advantage, is potentially making it much more widely accessible to people when they can do it from their own home.
Because I guess a good thing about you know, this body of research is that there have been a number of home-based programs which have been successful. So even though group-based programs, I mean, yeah, I think are really good and can, you know, the social aspects of those can really take over and people can be supporting each other and things. But even in the normal situation, that's still not for everybody. You know, some people are going to prefer to exercise at home. And so in our review, we did find that exercise programs at home, you know, could be taught to people and could still be effective. And people are probably aware the Otago home exercise program in New Zealand is a particular example of that.
Okay, so another question that I had was, so the review found larger effects from exercise led by health professionals, such as physiotherapists, and smaller effects for non-health professionals. So I'm asking the whole panel, what do you think were driving those differences?
I guess we have our training that for many years focused on how we prescribe different exercises and an awareness of the impacts of different functional impairments. And so one of the things I think that as physios we're quite good at is adapting exercises to different groups or for different people's needs. So if someone can't do a particular exercise as is recommended or prescribed, we have the ability to change the exercise to enable them to do it, or to prescribe a different exercise that might target the same system or the same muscle group. So I do think that's possibly one reason, and often too we have that one-on-one time with people, whereas possibly the interventions that were led by fitness leaders might have been all in a group setting. So maybe that impacted the ability to individualise the programs. As we always know, the challenges with group-based exercises. Some of my thoughts.
Yeah, definitely. I think as well, a big part of why physios are so great at prescribing those kind of exercises, knowledge of muscles and insertions as well is we're just we're just musculoskeletal guns when it comes to knowing you know, what the body can and can't do. And specifically you know, as an example, a lot of physiotherapists might, for example, know the difference between soleus and gastrocs, and the difference between training that versus not training that, whereas someone like maybe an occupational therapist or just an allied health assistant might not have the information or the training to know the differences between why you would train a specific muscle group and what the benefits of that would involve.
I mean, I agree with you both. One other thing I thought of, I don't think we've looked at this in detail, but I could be wrong, is that it could be also that physios and other health professionals, and particularly physios, I think, are more likely to be prescribing the more sort of functional and balanced, challenging exercise that we also found to be more effective. Because yeah, I think we have a good understanding about, you know, specificity of training and, you know, really the pretty basic concept that if we want to get better at something, we need to practice that thing. But, you know, there are still a lot of programs out there that do involve kind of more seated exercise and, you know, less functional approaches.
I actually did have a question, a follow-up question to this one. Do you think then, given the factors that we just listed, if we were to educate other professionals in task specificity and understanding the body from that perspective, would that then yield more positive results?
Yes, I think potentially. And to me, like an ideal system would actually have kind of links between different types of exercise provision. And so, like, I think physios could refer people to community exercise, and then maybe the physios actually had a role in designing those exercise programs and kind of checking that they fit with the evidence. And then maybe it could be delivered in that context, but then maybe the leader is sort of monitoring people, and if they are to deteriorate, then they could be you know, assessed again by the physio and have the program modified. So to me, that's kind of an ideal model. The other thing, there is some evidence that we can train other health professionals as well. So in the PEDro programs that I mentioned in New Zealand, the first trials that they did, the physiotherapists actually delivered the intervention. But then in their later trials, the physios actually trained nurses to deliver the intervention. But when people hear that, they think, oh, okay, you know, they went to a 1-hour lecture. But actually, it was a very detailed course that they did. I think it might have even been 2 weeks of training. And then they actually monitored the nursing intervention. So the physios were actually available to assist the nurses with the intervention as well, and sort of help oversee the intervention and the exercise progression and things as well.
I have a question based on the paper as well, just around the combination of balance and functional exercises with resistance training. So if I'm correct in understanding, there was a greater reduction in the rate of falls in that group, but less certainty around the evidence, so slightly less strong evidence. Do you think that future research should focus more strongly on this combination? Is that a gap currently, or I was just interested in your opinion?
That's a really good question. And yeah, your interpretation is exactly correct. So there actually was, even though the average, the overall pooled effect size was greater in those combined interventions, there actually was more variability. And so then that, and less quality of the studies as well. So that did bring down the certainty of the evidence. So that's why that gets a kind of may rather than a does type of conclusion. So yeah, I think we do need to focus more in that area. I think we also perhaps need to also get a bit cleverer about how we're actually categorizing different forms of exercise, because actually a number of those combined interventions, they actually still were, even though they met the profane criteria for strength training, they were actually still done in a functional way. So they still were primarily kind of more task related strength training rather than the more sort of seated exercise. But using the profane criteria the way we did, that doesn't quite come out. So we're keen to try and update that a little bit, and also get input from clinicians about that too, so that we can kind of better describe the interventions. Because it is an important point, and the previous Gillespie review actually had the conclusion that you need to have multiple component interventions. Mm-hmm. But the challenge with that is that then people only have a limited amount of time and energy. And so if we also know from looking at things in the other direction that the balance and functional exercises are most important, so we also don't want to be taking away from those in the idea that we need to be including other types of exercise. So I think people can be tempted to make sure they're including aerobic training and make sure they're including flexibility as well. But if we're most interested in falls, it does seem that we need to actually be focusing more on the balance.
Mm.
Would education also, I guess, could that be a part of a multifactorial component to training balance? Because I did read that Gillespie review, and it said in that review that education was still inconclusive, but if it's a multi-component strategy, could that also take part in helping reduce the risk of falls?
Yeah, that's a really good question. And so probably the best example of that is the study by Lindy Clempson and others from Sydney, the Stepping On intervention. And so that actually is primarily a kind of discussion-based education intervention, but it also has basically the Otago exercises in it as well. And, you know, that's a very effective intervention. And I guess that does focus on that kind of ongoing behaviour change and the sort of education aspects. But then it does also include the supervised exercise, and you know, people are probably aware of it, that, you know, in each session people actually do some of the exercises, and then they're also, you know, taught the exercises to do at home, and also asked to kind of report back on how they went with those. So it really is about that behaviour change and sort of teaching that home program. So yeah, certainly that can be a component, but you're right, other studies have found that just education is, you know, not enough. But I guess it's a key issue in terms of program scale up. So, you know, as we were saying before, we actually need everyone to be doing these type of exercises for the rest of their lives. And so, you know, we do need to work out smart ways of actually delivering that. And so, you know, a focus on behaviour change and, you know, ongoing interventions is really an important aspect of that.
I think we've discussed this to a certain extent, but how can we take the findings from this review and apply it to our own practice as physios?
Well, I think it's using any opportunity where we're engaging with older people to have the conversation around what types of physical activity they do day to day. I find that that's often a helpful way of starting that discussion, just talking generally about exercise, and then leading into the suggestion that there's certain types of exercise that might be more helpful or additionally helpful to them. Certainly when I see people in the emergency department, they've often just had a fall, and that is often a really good time to start that discussion, because they are aware that, you know, they are at risk of falls and injury, probably more so right at that particular moment. And so using that opportunity to have that discussion, to talk about what types of exercise to provide information, to make referrals. So I think in any interactions we have with older people, whether it's in a community setting, whether it's in a hospital setting, you know, as Kathy said, not just physios, but all health professionals in GP practices, having that conversation around, you know, we know this works to prevent falls. These are the types of exercises we know works. How can we get you involved doing these? And I think because there are so many options for people, they don't have to attend a group if they don't want to, etc. We can often work out something that they find acceptable as a way of starting to engage in those types of exercises.
Kathy, I don't know whether you looked at the ideal, I guess, exercise, like frequency, intensity of the falls prevention program. Did you do a subgroup analysis on even just the duration of the programs that the participants did?
So for the Cochrane review, we didn't actually do that, just because of the way it kind of works in the software. You kind of can't have too many different subgroup analyses. So we focused more on the inclusion criteria and also, you know, in terms of whether people were at high risk or not. as well as the type of exercise. But for our a previous non-Cochrane review that we did actually basically work out that a longer lasting program was more effective, and really it was at that median cutoff. So I think it was 3 hours a week of exercise over the program duration, which is kind of in keeping with what the physical activity guidelines are as well. We've actually also got another paper, which I don't know if you want to share as well, with a student. Ng Ning is the first author, and it actually sort of accompanies this paper and just describes the components of the programs in a bit more detail. As well, so just because it can be a bit unwieldy in the Cochrane review itself, so he's kind of pulled out what the actual programs looked like in the types of interventions that were effective.
I actually did have a question. I noticed that many of the trials had females exclusively, and so my question was, could gender or culture have skewed the results in any way, potentially favouring an exercise modality over another one?
Mm-hmm. Yeah, potentially. And, we do comment that we actually need to have a lot more trials done in different countries. So there's some now, there's more in this version than in the previous version. But yeah, we do definitely need to have more types of programs. I mean, and yeah, in terms of gender, I think that's right as well. I mean, there are a number of trials that actually have mixed participants, so that have men and women. And certainly anecdotally, and I think some evidence as well, people say we might also need different marketing, among men as well. But I guess, physiologically, in terms of kind of gender and culture, it kind of, we would imagine the same things would apply. More coming down to that implementation and the program acceptability and uptake and, marketing and, those types of issues where, things might vary. And there have been some good examples of, different programs in different countries, that have sort of fitted more with, more traditional exercise in those countries. So it wasn't big enough to have a falls outcome, but I was involved in a trial recently with some Brazilian colleagues about sort of dancing, and particularly, Brazilian kind of dance for older people. So yeah, that's definitely the sort of thing that we need to explore more. In terms of further comment, I just wanted to say I fully agree with what Jamie said before about implementation and about how we really need to be taking every opportunity with an older person, and indeed with other health professionals, to get this message out there. Really the extent and the strength of this evidence is really quite overwhelming, but I think the awareness in the community and also in the general amongst health professionals is actually very low compared to the strength of the evidence. And so, yeah, I think we need to be having a role in that.
Older people are always very surprised when running groups or one-on-one interactions, if you tell them, if balance exercise or exercise in general was a pill, it's practically the only medicine that everyone would be on. It's that good for you. And I think that really makes them think, because they're quite used to being given tablets for illnesses and ailments or to improve their health. And so reframing something that they can do for their health that is supported by doctors, physios, health professionals generally, I think is, they always seem as a good way forward when they think about it in that context, has been my experience.
I would just like to thank everyone on the panel, Kathy, Jamie and Nadine, for being part of the Worldwide Journal Club for PEDro. And I would like to thank the viewers as well for joining us today.